We're good. Okay. All right, guys. For like any students are here, I'm Dr. Shaw. I'm one of the pulm crit care doctors. So I'm gonna talk about diagnosis and management of asthma. I apologize for any word finding difficulties I have today. I just got it through a morning of interviews, so but we'll get through it together. All right, so it's sort of this is more geared towards outpatient asthma management. We're not going to talk too much about asthma exacerbations and things like that. I don't find that as cognitively difficult as actually outpatient asthma. So we're going to talk about this a little bit more. As in most of my lectures, if you guys have been a number before, I try to separate between what things you need to know in life for this topic and what things you need to know for your exams. So I'll try to point that out as we're kind of going through the lecture, but we're going to review the definition and diagnosis of asthma, outline important pathophysiologic pathways of asthma. We're going to describe some management strategies for asthma maintenance, and then we'll go through like a brief case-based approach to asthma and sort of what your boards like to ask about asthma. All right. Okay, so this is a little old, the numbers, but it just gives you kind of an idea of the asthma burden in the United States. So 7.6% of adults in the US population with asthma, and this is from 2015. So again, it's older, but almost half of the adults with asthma report exacerbations at least once a year. So you can imagine that the burden for asthma on the healthcare system can get pretty high. And oftentimes these exacerbations are mismanaged as like they're treated with antibiotics. You know, if you go to the doc in the box and you get the classic steroid and antibiotic injection, but then nothing else, you know? So we want to talk about sort of being able to properly diagnose and manage asthma in the outpatient setting. So the definition of asthma is a disorder of the airways that's characterized by variable recurring symptoms of airway obstruction, hyperresponsiveness, and inflammation. So the key parts of this definition that make it different from COPD, okay, is the variable nature of the symptoms. That is what makes it different from COPD, okay? So basically what happens is that there's a loop of airway inflammation, and then there's certain cytokine response that causes smooth muscle constriction, which then again feeds into your airway inflammation pathway. And so when we talk about kind of how that happens, we can kind of look at this figure. So if you look at asthma, usually there's some trigger. Usually there's an allergen trigger. So when you have your allergen trigger, you have stimulation of helper T cells to produce IL-4, IL-13, IL-5, which all stimulate different things. So IL-4 and IL-13 will stimulate smooth muscle constriction. IL-4 will stimulate B cells to produce production of antigen-specific IgE. IL-5 is going to stimulate eosinophil migration. And those things are important because they are targeted pathways for severe asthma. So it's not just a figure that you sort of just pushed off to the side, because all of these are actually targets for biologics for asthma. So that's why it's important. So smooth muscles, IgE, and eosinophils are kind of key things in asthma management. The other thing that's new is this TSLP here, which is another kind of factor that's upstream that kind of helps also with increasing the helper T cell population. And that's like a new biologic that's out there, which I'll talk about towards the end, but we'll kind of go over that. It's not as emphasize on this slide because it's from 2014, but they are using it as a biologic right now. Okay, so symptoms of asthma, throw it out there. What are our symptoms for asthma? Cough, shortness of breath. What else? Chest tightness. What else? Wheezing. Okay. So those are the main ones. Okay. And just remember that your symptoms are going to be different in asthma versus COPD, and that it's episodic and variable. Okay. Whereas COPD is very predictable. So when you're asking a history, that somebody who could have either COPD or asthma, a question that I like to ask is how, is it pretty predictable that you know when you're going to do something, this particular activity, you're going to have shortness of breath? Okay, if it's pretty predictable, then that goes more, it's more commonly for COPD. Whereas if it's a little bit more like they're not sure when they're going to get hit by symptoms, that's variable and that's more consistent with asthma. Okay, so when you have somebody who you're concerned about potentially diagnosing with asthma, the other kind of review of systems, so, whenever you're in, you have a chief complaint in a certain organ system, there's a kind of focused review of systems that you can do. And for asthma, that will be asking about triggers. So a lot of patients will say like, oh, when my wife's perfume, it causes asthma, like causes my asthma to flare or whatever. So you want to ask for triggers. You want to ask if they have any other history of atopy. So eczema, things like that, allergies, pets, what pets they have in the home. This is like a little bit of a touchy subject sometimes, because they'll be like, they know, people who know that their pets are causing their symptoms or exacerbating their symptoms will say, I have a dog, but I was tested and I'm not allergic. Okay, that'll be their response. But anyway, pets, you want to get a history on your pets. The cleanliness of their home. So is there any visible mold or mildew anywhere? Is there a lot of dust, things like that? And then you want to get a history of, especially somebody who is already diagnosed with asthma, how frequently they have exacerbations, how frequently they have hospitalizations, and if they've ever been intubated before, because that will give you an idea of whether or not how severe their symptoms are. Okay. So physical exam, you guys know this, you want to look at whether they have wheezing, prolonged expiratory phase, how the respiratory rate is, and their accessory muscle use. Okay, pretty basic stuff. All right, so let's go over diagnostic testing. So if you see somebody in clinic who you are concerned about could have asthma, and they present with all the symptoms, what diagnostic testing could you do to help you decipher that? PFTs. And what do you expect your PFTs to show? Reversal of what? Reversal of obstruction. Okay, good. So on your exams, most likely when they show you a pulmonary function test, they will show a reversible obstruction for if they want you to go towards an asthma diagnosis or treatment option. But in real life, most commonly asthma actually presents with what pattern on PFTs? Normal. Yeah. So most often you will see normal pulmonary function testing in patients with asthma. Okay. So just quickly, I go over this in the asthma lecture just because there's no other place for me to tell you guys this, but when reading pulmonary function testing, you can use either the GOLD criteria for reading pulmonary function tests or the American Thoracic Society. So on your exams, they usually talk about GOLD, which is if you want to diagnose somebody with an obstructive lung disease, what number are you looking at on your pulmonary function test? Okay, and what is abnormal for that number? Yes. Okay. Okay. Good. So abnormal is less than 70. And so that's gold. For American Thoracic Society, so if you think about it, having a set number of 70, and if you're doing a pulmonary function test in a 20-year-old versus a pulmonary function test in a 90-year-old, you can imagine that their normal lung function is going to be vastly different. And so having like just one number to define a lung disease seems like it wouldn't be like a good way to read pulmonary function testing. So American Thoracic Society uses the lower limit of normal. So what they basically do is they graph everybody with the same age range, race, ethnicity, and sex, and they plot it out. And then they consider abnormal if they're below the lower limit of normal here. So you'll see if some of us who read pulmonary function tests will say that somebody's maybe normal, even though their FEV1 over FVC is 68, because it's still above the lower limit of normal. That means that they are expected for their age is probably a little less than normal, okay? Okay, so this is what you guys were talking about, right? So reversible airway obstruction. So if you look at this spirometry, this patient's FEV1 over FVC is 68, okay? After bronchodilator, it goes to 77. So before bronchodilator, it's obstructed, and after bronchodilator, it is not obstructed. So that's reversible airway obstruction, and that's most likely how your PFT is going to present on your exams for asthma questions, okay? So this is just another, a summary of that again. Obstruction, reversibility with bronchodilator. And in terms of this actually should say bronchodilator response. Usually for asthma, it's also nice to see a bronchodilator response, which is a 12% change in your FEV1 or FVC, or a 200 ml change in FEV1 or FVC. And so we talked about, does normal spirometry rule out asthma? It does not. So even if you have normal spirometry, you still could have asthma. So the way that you kind of test more definitively if somebody has asthma is called a bronchoprovocation test or a methacholine challenge test. And what that is if somebody has normal pulmonary function tests and you're still suspecting asthma, you can send them for this. And basically what happens is the respiratory therapist has them nebulize methacholine, which is going to induce bronchospasm at increasing concentrations. And each concentration, they're going to do a spirometry. And what they're looking for is a 20% decline in the FEV1, okay? When that happens, then they figure out what concentration it happened at, and then you get an interpretation of how airway responsive, how hyper responsive they are. And so that's the gold standard for diagnosing asthma, is a methacholine challenge test, okay? So if this is negative, you most likely do not have asthma and you have an alternative diagnosis, okay? So some of the ancillary testing that you can do for asthma is allergy testing. So sending to an allergist for the skin allergy testing, getting an eosinophil count, and getting an IgE. Why are getting those things important potentially for people who have more severe forms of asthma? Yeah. Mm-hmm. Yes, definitely. Yeah. So the allergy testing is going to help you figure out what in the environment maybe is triggering these things, and also being able to treat comorbidities. So, right. So if somebody has a lot of allergic rhinitis, that can also be treated by knowing sort of what their allergen source is, and uncontrolled allergic rhinitis can worsen your asthma, okay? So that's why for people who are starting to become a little more difficult to manage for their asthma, getting this testing is important. Okay, so symptom severity. So this is a high yield table, okay, for severity of asthma. So your mildest form of asthma is going to be mild intermittent asthma, okay, and it's all defined by how many daytime symptoms they have, how many nighttime symptoms they have. That's usually what is on your exams, but they also include in real life how often you're using your short-acting bronchodilator and your actual lung function, okay? So you'll see that daily symptoms during the day start at moderate persistent asthma. And that seems to be like a breaking point where people like to ask exam questions is at the moderate persistent asthma category. Because that's where you go from having symptoms 3 or 4 days a week to daily symptoms. And that's where there's a big change in the treatment that you're going to recommend, which I'll go over in a second. But you do need to know this table for asthma severity. Okay, and that table is going to help decide what you're going to give to patients for management. Okay, so most of my recommendations for asthma stuff come from the GINA guidelines, which is an international society for asthma, where they review the current data every year and put out like a statement on what's new and what like gold standards in terms of diagnosis and therapies there are. So I use GINA. There is a US group as well, but that's just how I was trained, was using GINA. So this is from their strategies, and this is from 2015, but they still use this. So you want to continuously assess and make sure that you're revisiting your diagnosis, checking inhaler technique and patient preference. So that includes like what's covered by insurance. And then you're going to adjust your treatment, and then you're going to review your response, and then you're going to do that all over again. Okay. Asthma is notoriously, obstructive lung disease is notoriously difficult to treat because inhalers are not great. They're very expensive. There's a lot of issues with how people use inhalers. So kind of going through this pathway of continuously reassessing is extremely important. Okay, so some non-pharmacologic strategies. So before I talk about inhalers, let's talk about the other things that people can do to help manage their asthma. So it's something called asthma hygiene. So this is something that you can counsel your patients on to help them improve some of their asthma symptoms, things in their environment. What do you guys think that would be? Yeah, fabrics like curtains, yeah, things like that. Try to avoid having those in your house, especially the bedroom, because they spend the most time there, right? What else? Pets, yeah. Again, a touchy subject. But things that I like to suggest, if obviously they're inseparable from their pets, is maybe not in the bedroom, not sleeping in the bedroom, or that way you have some space that's a little bit protected from that allergen, would be a potential recommendation. What else? Yep. Good. What else? Yeah, look any taking care of any exposed mold, mildew, just dusting in general, being good about that. Washing your bed sheets with hot water every 1 to 2 weeks, and using hypoallergenic covers on your mattress and pillows. Okay, so underneath your bed sheets, you have a hypoallergenic cover. That keeps like dust mites like from your from inhaling them, basically. So that's sort of some of the things for asthma hygiene that you want to counsel patients on. It's not exactly evidence-based, but everyone does it. Like all the pulmonologists will talk about those things. But to be honest, there isn't actually any high evidence quality on whether that actually helps to improve asthma symptoms or exacerbations. It definitely can. Often that's not terribly modifiable, but it can for sure. Yeah. Okay, and then going over an action plan. So this is an asthma action plan. And this kind of ties into medication as well, but kind of going over with a patient sort of what they're going to, what their ideal peak flow is and what they're going to do based on how much the peak flow has reduced. Like, are they going to use an albuterol inhaler first? Are they going to have prednisone at home that they take if their peak flow gets to be in the severe range? So kind of filling this out for them is can help prevent more contact with the healthcare system. For you guys at Dotson, if you want to, you can send people to the pulmonary function lab to get this made by the respiratory therapist. So they'll give them a peak flow and they will make an asthma action plan with them. And just also give them inhaler education. So you want to, if you want to send somebody there, it's just the order is PFT and the checkbox is peak flow, and they'll do all this for them. Yeah. Sure. I do believe there is. Do I know it? No, I don't. But I do think there is. It's by the same people who like research the N95 masks and things like that, and what's like actually does filter particles and stuff like that. So it's mostly in like the occupational medicine world. So there is data. I just don't know it. So okay. They don't go over it a lot in GINA too. So. Okay, other non-pharmacologic strategies is weight loss. So I have a patient who got gastric bypass and lost 100 pounds, and she used to require steroids every month, and she's gone a whole year without requiring any steroids. She still uses like maximal inhalers, but she used to every time tell me she's short of breath still, despite maximal therapy and all that. She had been on Xolair, she'd been on all the things. And then she lost 100 pounds and now she's like totally fine and on her maintenance inhalers. And so weight loss definitely helps, and that should not be minimized. And then the other thing is that you want to assess inhaler adherence. Now you guys know, like, I mean, I'm sure you guys don't even know how to use most of the inhalers. They're kind of complicated. And you can imagine what? Yeah, and they're all different. And so inhaler adherence is something that does need to be checked if you've got somebody who's on inhalers and is still not having symptom control. And one way also that you can help that's simple is for MDIs, those puffers that you push and they and medication comes out. You can prescribe a spacer for that. And that could be an easy way to improve medication administration. So a spacer is a long tube that attaches at the end of the inhaler, and then the patient's mouth goes on the other end, and it allows them to, you can push the inhaler and the medication kind of gets into the long tube, and the patient can just breathe in and out in like a comfortable manner instead of timing it with the pushing the inhaler. And it helps to get the medication into the lungs rather than to the back of the throat. And so that's an easy way to sort of help with that inhaler adherence kind of situation. But it only works for those MDIs. It doesn't work for things like if you guys have seen Trilogy and Brio and those kinds of inhalers, it doesn't work for that. Okay. And then we talked about asthma hygiene. Yeah.
Are some of the round
those are like powder inhalers. I don't know what the technical name is, but it's like they, so what that means is that you don't, it doesn't spray at you. You have to inhale it. So that matters for your elderly patients who might be a little weaker because they won't be able to inhale the medication out of it. So like those Advair is a purple disc. Advair's like that. Brio, Trilogy, Increws, those all require some, you know, a good inhalational effort, and that's something. Yeah, and it sprays. Yeah, it sprays. So yeah. So the Handihaler is the pill, and the Respimat is a twisty one that sprays a mist. So both are complicated. It's just the pill, I think the pill is a little easier than the twisting one. But you just have to be clear and tell them that they don't swallow the pill, they put it in the inhaler. And then that does require more of an inhalational effort for the Handihaler. The 340B program, you guys have that through Dodson too, right? That one for Spiriva, it's only the Handihaler, not the Respimat. Okay. No, not for either, for Spiriva. Yeah. Okay, so any other questions about inhalers, like mechanisms? I guess another tidbit is Advair is generic, is Wixela, which has an even more complicated mechanism, but it's cheap. So if you have patients who need that, Wixela is like the generic of Advair. It's really the only generic really inhaler that exists. Okay, so this is another high yield slide. Okay, so step up therapy in asthma. So depending on what you have classified your asthma severity is what you're going to try to start the patient off on for medication. And so if you look at like mild intermittent and mild persistent, you're going to start off with a short acting beta agonist, and you can consider a low dose inhaled corticosteroid in those mild intermittent and mild persistent categories. So the high yield part of it is asthma. For asthma inhalers, the thing to start is an inhaled corticosteroid. That is your first long-acting inhaler. Okay. You can get away with mild intermittent asthma just starting a short-acting beta agonist, so albuterol, PRN. But then your next step is always going to be an inhaled corticosteroid. Okay. Yes. Yes. Some of the recent literature does support using a low dose inhaled corticosteroid as a PRN basis rather than a maintenance inhaler. I don't know if that has migrated to the boards yet, but it is definitely in clinical use. So, yeah. And is that only in step one? Yes, yeah, only in step one, because then after that, you want to use it not as a PRN, you should be using it as an everyday inhaled corticosteroid. Then it becomes maintenance, right? Yeah. So then as you step up, you're going to add in your long-acting beta agonist, okay, in combination with your inhaled corticosteroid. So you're never without, after mild persistent asthma, you are never without an inhaled corticosteroid. And then as you step up, you're going to try to increase your dose of your inhaled corticosteroid. And then for severe, you're going to add on, for both step 4 and step 5, you're going to add on your anticholinergic and your biologics at that time. Okay. Leukotriene antagonist. So that is singular. Singular can be added anywhere after mild persistent asthma. Okay. To be honest, there's not a lot of evidence that singular improves symptoms or exacerbations, but people use it. It's on the guidelines. Okay. Not as high as inhaled corticosteroids. So I mentioned that this moderate persistent asthma category is where like your therapy kind of changes drastically. And so that's like a high yield area where they tend to test a lot, is at that, severity. So that's where you add your long-acting beta agonist. So that's why that tends to be a spot that they like to test on. And that's also where you start to have daily symptoms of your asthma. Okay. That doesn't mean they don't test about the other ones, but they tend to have moderate persistent asthma a lot on things. Okay. Any questions about step-up therapy? So why an inhaled corticosteroid first? So part of it is, you know, if you think about the pathophysiology, it makes sense, right? You have such a big inflammatory response. You want to try to decrease that with an inhaled steroid. And then early studies, when they kind of looked at an inhaled corticosteroid and compared it to long-acting beta agonists, they found that your number of exacerbations were less with an inhaled corticosteroid. And so that's why, that's where it all kind of got started. And then that data has been able to be replicated throughout the years. Okay, so leukotriene inhibitors, which is Singulair most commonly, is a, will basically block the prostaglandin pathway to the smooth muscle constriction. And that's how leukotriene inhibitors work. And like I said, it's not a magical effect. And I try to counsel patients on that Singulair is not going to like give them a dramatic improvement in their asthma. So something to just kind of temper the expectations for treatment. All right, so theophylline. So if you look at the step up, they throw in theophylline here and these other controller options, okay? Clinically and culturally in the pulmonary world, theophylline has fallen very much out of favor for both asthma and for COPD. It is also kind of theoretically, it's supposed to be a PDE3 inhibitor, so it decreases smooth muscle constriction. And it's supposed to help increase the action of your bronchodilators. That's what the theoretical effect is. Theophylline has a lot of issues with titrating drug levels, has cardiac toxicity, and just generally hasn't been shown to be that effective for what it's marketed as. So it's fallen out of favor with a newer kind of younger pulmonologists. But you'll still see people on it. So I just wanted to let you know. More commonly with COPD than asthma, but it's still there in the step-up therapy. Okay. Okay, so what happens if you put them on the appropriate step-up therapy for asthma and your patient is still not controlled? So what does not controlled mean? So a lot of us have sort of some like objective questionnaires for this, because sometimes like people will have different like subjective sort of feelings on whether their asthma is controlled or not. So some people will say, oh, my asthma is not controlled because I use albuterol once a week, but that's considered pretty good control. Whereas you'll have other patients who will be like, my asthma is really not bad, but they're like waking up several times at night to use their inhaler. So sometimes having these types of questionnaires can help to get more of an objective sense of what's really going on for a patient. Now, if you don't have these kinds of questionnaires, some of the things you can ask is how often they're having asthma symptoms during the week, nighttime awakenings, if they're using their albuterol more than twice a week, and if they are limiting any of their activity because of their asthma. So like they should not be waking up at night at all to use their albuterol inhaler. If they are, then that's not considered controlled. Okay. Okay, so this is actually from COPD data, but first thing you want to know if somebody is not well controlled with their asthma is if they are using their inhaler correctly. Okay. And so this was a study where they looked at, they had these inhalers where they had like recording devices in them, and they kind of looked to see what types of errors patients were making with their inhalers. And so the most common thing is a low peak inspiratory flow. So they're just not inhaling strongly enough to get medication in. Okay. For those types of patients, you may want to consider a different type of inhaler that's administered in a different way, or a nebulized version of the inhalers. And then you've got people who did multiple inhalations with one click of the inhaler. They had more than one error going on. Some people were exhaling into the mouthpiece. So there's a lot. So checking to see, make sure that the inhaler is actually being used properly is the first step with uncontrolled asthma. Okay, let me skip this slide. Okay, so the other thing that you want to keep in mind when you have patients with asthma who are not doing well is to think about things that are going to affect their outcomes. So that you want to be vigilant about these patients potentially being higher risk for not being controlled. So if they've had prior intubation, if they've had many asthma exacerbations that have resulted in emergency room visits, if they don't take their inhaled corticosteroid consistently, right? So if you've got somebody who say is self-pay, and every time you see them in clinic, they're like, oh, I'm not on my Symbicort because I couldn't afford it. And that happens several times. That patient's at pretty high risk for having some sort of bad outcome from their asthma, or like multiple like ER visits, doc in the box visits for asthma. And then if they have like certain social determinants of health, that will also decrease their adherence to the corticosteroids. So depression, substance abuse, personality disorders, unemployment, things like that. Okay. So I'm a firm believer that asthma does not need to be referred to a pulmonologist all the time. Okay. I do think that primary care, that a primary care physician can take care of asthma, but there are, to a certain extent, but I think that there are certain situations where you should consider referring to a subspecialist. One of them is before bronchoprovocation testing. So if you've got somebody who you're still suspecting asthma, but their pulmonary function test was normal, and you're not sure whether therapy is helping them or not, it might be a good idea to refer before getting the methacholine, because that requires whole interpretation and stuff too. Abnormal imaging. So this CT scan is a CAT scan of bronchiectasis. So if you have bronchiectasis and asthma type symptoms, what syndromes does that make you think of? Fungal, it's associated with the fungal infection. Sorry, say that again? Yes. Okay, so allergic bronchopulmonary aspergillosis. Okay, so that's going to be asthma and bronchiectasis and aspergillus positive. Okay, so that's going to be a very different therapy and management and diagnostics compared to a simple asthma. So abnormal imaging is going to probably be suggested that you refer. If you have restrictive lung disease, because that means you're probably not dealing with asthma, you're probably dealing with something else. So you may want to consider referring for that. If you can't get their symptoms under control, I don't know why I put this here, but you may want to consider also referring to an allergist if you have somebody who's like not controlled. All right, so let's talk about refractory asthma management. So you've got somebody who you've got them on all the inhalers, you've got them on the Singulair, and they're still having nighttime awakenings, they're still having daily albuterol use. So what things can you do to help with that? So the first thing is to reconfirm your diagnosis. So one of the common questions on your guys' exams is that you have a patient who comes into the emergency room with a diagnosis of asthma, is wheezing, short of breath, using accessory muscles. On exam, you hear wheezing, and they end up intubated and they're no longer wheezing. So what is the diagnosis? Yeah, like could be a malignancy, but the one that they're usually looking for is something else. It could be a malignancy, but usually the more common answer is another diagnosis. That's more variable. Whereas a malignancy is going to be like a fixed upper airway obstruction, which is correct, but something that's more variable. Upper airway obstruction. Vocal cord dysfunction. Okay, so that's a common question. So they come in looking like an asthma exacerbation, they get intubated, and they're no longer wheezing. It's because the vocal cords are not in play anymore, right? So that's a common board question. Okay, so that's my point of that was that reconfirming the diagnosis, because people can have vocal cord dysfunction and not be intubated. Like, I mean, they can just have it in the outpatient setting. And so you want to reconfirm your diagnosis that you're actually dealing with asthma and not something else. So then we're going to talk about anti-IgE and anti-IL-5 therapy. Actually, I didn't update this slide. There's also anti-IL-4 therapy as well, which we'll go over. And those are the biologics. The other thing that you can consider, and this is not high evidence, but people have been doing it and extrapolating this from the COPD data, but you can do a chronic macrolide, which is chronic azithromycin, and that's thought to be anti-inflammatory. So you can do that 3 times a week, just like you for refractory COPD. You can do a chronic oral glucocorticoid, which you try to avoid, but for asthma patients, sometimes they can't live without it. So that might be something that you need to do. Theophylline, although we talked about we're trying to go away from that, but that is on the list. And then bronchial thermoplasty, which is basically kind of a heat therapy that you can do for the airways bronchoscopically to help reduce smooth muscle constriction. Okay, so other diagnoses that can present like asthma, COPD, vocal cord dysfunction, heart failure. So pulmonary edema, you can have wheezing from that. Bronchiectasis, we talked about ABPA, cystic fibrosis, and then mechanical obstruction. So sometimes if you have foreign body aspiration, like if you've aspirated a tooth, you can have wheezing from that. Okay, so that's reconfirming your diagnosis, okay? So differential for asthma. This can be high yield also. People like to test on this stuff too. All right, so let's talk about biologics, okay? So all of these cytokines are have an integral part in the inflammatory pathway for asthma. IL-5 is one that will stimulate eosinophil production. And then IL-4 and IL-13 are going to be related to IgE mediated issues. Oops. Okay. And then the newer upstream target is this TSLP, which they've just been like writing about in the journals this year, where it blocks this TSLP cytokine, which helps to promote the helper T cells that then produce the IL-4 and the IL-5 and the IL-13. So it's a little bit more upstream, and that's being considered to use for refractory asthma as well. So for anti-IgE, we have omalizumab. For IL-5, there's actually like 3 targets here: mepolizumab, reslizumab, and benralizumab. And then for IL-4, we have dupilumab. So here, this is our newest biologic here at Erlanger, like that we've been using. And then we've all been using omalizumab and benralizumab. And then the tezepelumab, I have not seen used yet. Okay. So these are sort of the indications, and they all have like an eosinophil count or an IgE count before you start to use it. Okay. So like I said, we have all of these except for tezepelumab and reslizumab, we don't have either. Okay. All of these are infusions, or sorry, are auto injections, but they have to be done at the infusion center. And that's like a Medicare requirement. So it's kind of annoying because like a lot of these patients, they're like diabetics and they do their insulin at home, but then they have to come in to do their like auto injectable asthma pen. But that's sort of what they what the like workflow is. So you can imagine for people who have transportation issues and things like that, like coming in every month for that injection may be a problem too. So something to keep in mind for that, but okay. Okay, so in summary, before we go through some question kind of things. So asthma is defined by an obstructive defect and variable symptoms, obstruction and variable symptoms. Your pathophysiology is going to be smooth muscle constriction, inflammation in response to an antigen. Your management of asthma should start with non-pharmacologic interventions, and then you're going to do the step-up therapy, okay? And that step-up therapy is high yield for your exams. And then you're going to refer for recommendations on therapies outside of your inhalers and singular, okay? In terms of where it is your kind of the primary care management end and where does it go to a kind of a subspecialist. Obviously, everyone's comfort levels are different, but that's sort of, in my mind, I feel like that's where like the line is for referral versus primary care. Okay, so let's talk about a question. So this is a standard kind of question that might come up. So in which of the following clinical scenarios would you use a low to medium dose inhaled corticosteroid and a long-acting beta agonist to treat a patient's asthma? So what did I tell you about when you add the long-acting beta agonist? That means what's your severity of asthma? Moderate persistent asthma, right? So which one of these options is that? Good. Okay. So step up there. Frequently at night. So that becomes severe.
So frequently doesn't mean like
No, it's like almost every night you're having symptoms. Whereas the A is you're having it at night, but not like every night. Okay. All right. So step up therapy, high yield. Okay. All right, so you're seeing a patient in follow-up for moderate persistent asthma. The patient's already on an ICS and LABA and continues to have shortness of breath 3 times a week and has woken up at least once a month with nighttime symptoms. These symptoms are an improvement from when before he had therapy, and he's happy with the results. Should you increase his therapy? If yes, what would you try next? Okay, yes.
sounds like he's doing pretty okay. I would, at least from what he said,
A question back there, Eli. He's on a high dose inhaled corticosteroid. Yeah, you could argue that you should add something because he really shouldn't be waking up at nights with symptoms. So he is feeling better, but he's probably still not fully controlled, okay? Because you're looking to be symptom-free at night and really only like 1 or 2 times a week of albuterol use, okay? And that's the chart on the control. Okay. Yep. So he's got nighttime awakening. And he has more than twice. Yeah. Okay, so, and then you're right. So anticholinergic would be probably what you would add next for this patient. If they were just on a medium inhaled corticosteroid, you could increase it to a high dose too. Okay, and then you guys know this one, the environmental changes for a patient who has asthma. You guys got those all correct during the presentation, so we won't go through that again. Okay, any other questions? So just resources for inhalers for your patients in Dodson. I always like to go over this when I'm in lecture. So you have your 340B program, right, for cheap inhalers. Each of the inhalers have a drug assistance program through the company, the pharmacologic company. So if the patient's income requirements are met and then they fill out the forms, they can get a year's worth of free medication. Okay. If they are really having trouble getting inhalers or anything like that, you can, a poor man's way of doing it would be to order them a nebulizer, which is usually $25. And then nebs are pretty cheap. You can get them for $4 a month for albuterol nebs. Okay. So if you can't do anything else, then you can do albuterol nebulizers because oftentimes ProAir and Ventolin can be expensive too. They also make these pocket nebulizers. I think they're like $50 or $60 that are you can keep in your pocket. That's a nebulized version. So then the medication in there is pretty cheap. So it's like a one-time cost of the $50, $60, and then the medication is pretty cheap in there. And then I think that's pretty much it in terms of resources. If you guys need anything for your patients. Okay. Anything else? All right. Have a good day.